So, good evening. We are very happy to have the next session of PG Club of IAP President's Action Plan. And this time we have very good faculty. One is our own Professor Lalitha Kailas, previous head of Department of Pediatrics, SAT Hospital, and now she is the principal of Gokulam Medical College. Dr. Lalitha Kailas doesn't need any introduction. Or the pediatricians as well as the students all over Kerala and maybe India may be knowing Madam very much as a very good teacher. And her classes are always complete and it's full of information. And she is a very strict teacher also. So even a minor point, she will find it out. And the second, next faculty, the expert faculty of gastroenterology is Dr. Maya Peethambaran. She was also with us and she was actually joined as a assistant professor in pediatrics first, and then she went for the gastroenterology, and now she is working in Lakeshore Hospital as associate professor and associate as consultant, and we'll hear from her also. It is very happy to have Dr. Maya with us. And now Rukmini has joined, and I invite Rukmini to just say a few words.
Good evening. It's really happy that our PG classes are going on like this. And respected Lalitha Madam and Joseph has joined, and Dr. Maya Peethambaran, the expert from Lakeshore Hospital, welcome. And I know with all these faculties, it will be a very good session. And now, thank you very much.
Thank you, Shanava sir, coordinating all the academic activities of PG Clinical Club, and the president of IAP Trivandrum, Dr. Rukmini Madam, secretary Dr. Bino. Today the faculty Lalitha Madam, Dr. Maya Peethambaran, Dr. Gopika, and Amritavari PG, who is going to present the today topic. As you know, we are conducting regularly in the every Thursday. This program is very much is encouraged by the participants and response from the participants. That's why we are, even though today the Madam, we are again continuing the program for to this weeks also. I think the response from the outside Kerala is very encouraging me as, because they are asking for the link, and every after the program they are asking for the Zoom link, the YouTube link, and then for their interest in regarding the PG Clinical Club. I think today there is already Dr. Kalpana Madam mentioned there is no to introduce Lalitha Madam. So everybody know that as a excellent faculty at the PG teacher at the national level. So they will be enlightening all of the PGs regarding their clinical skill in the approach of common issues in pediatric practice PG cases is concerned. I wish all the best program, and over to Dr. Kalpana Madam to further proceedings.
So today the case will be presented by Dr. Silpa Sekhar from Anandapuri, and Dr. Gopika is the mentor. Dr. Gopika is also an alumnus of SAT Medical College. So it is actually a family get together actually.
Thank you.
So over to Gopika.
So our Silpa, since the time it's already late, we'll straight away go to the presentation. She's presenting a case of an adolescent boy with the jaundice. The dilemmas we faced when this child came to our hospital. Over to you, Silpa.
Thank you, Madam. Good evening to all the eminent faculty and all the respected doctors assembled here. Today, I'm going to present the case of Master HS, a 16-year-old male hailing from Nagarkoil, and the information was collected from the patient and the father, and the history is reliable, and he was examined on the first day of admission to our hospital. His presenting complaints were fever since 10 days, with yellowish discoloration of eyes, palms, and soles noted since 7 days, with abdominal pain and vomiting since 4 days. History of present illness. He was apparently normal 11 days back when he developed fever. It was a high-grade intermittent fever for which he was given symptomatic management from a nearby clinic. And the fever was associated with anorexia, malaise, generalized myalgia, frontal headache, and an occasional dry cough. And there was no history of any chills or rigors, dysuria, vomiting, loose stools, abdominal pain, or rashes in the initial days of the fever. Since symptoms persisted and parents started noticing yellowish discoloration of his eyes, he was taken to a nearby hospital on the 3rd day of illness and got admitted for evaluation. Blood and urine investigations were done there, and parents were informed that he had a liver disease as seen by his reports, and he was started on IV medications and IV fluids. And on the 2nd day of admission, that is on the 5th day of illness, he was given transfusion twice in view of low blood counts. And fever persisted with headache, increasing myalgia, and a deepening jaundice. And on the 7th day of illness, he also developed an upper abdominal pain with non-projectile, non-bilious vomiting and a decrease in urine output as noted by the patient, and which persisted in the subsequent days. And since his symptoms persisted, he was referred to our hospital on the 10th day of illness for a detailed evaluation and management. There was a history of passing high-colored urine, but no history of any pale color of the stools or pruritus. No history of melena, hematemesis, or other bleeding manifestations. No history of facial puffiness, pedal edema, or abdominal distension. And he had no history of any sleep disturbances, altered sleep pattern, behavior changes, decrease in scholastic performance, memory loss, or any abnormal movements. And on eliciting his personal history, he was an active football player who used to play football in the nearby fields. No history of any rashes noted during the period of illness. No history of recent travel to outside. No history of intake of any herbal or indigenous medications. No similar illness in close contacts. And no history of any recent weight loss or TB contact in the family. Past history. There was no history of any similar episodes in the past, no history of any recent hospital admissions, surgeries, or blood transfusions. He is not on any regular medications, no known drug allergies, and no history of any addictions, IV drug uses, tattooing, piercing, or needle pricks. Coming to his birth history, he was the firstborn of a non-consanguineous marriage, and the mother had regular antenatal checkups, and there was no significant history of any fever with rashes, gestational diabetes, gestational hypertension, urinary tract infections, bleeding or leaking per vaginum in the mother. And he was born full term at 37 weeks by a normal vaginal delivery and with a birth weight of 3.3 kg. And he had cried immediately at birth. And the breastfeeding was initiated within 1 hour. And he had passed urine and meconium within 24 hours and no history of any significant NICU admissions in the immediate postnatal period. Dietary history. Breastfeeding was initiated within 1 hour and he was exclusively breastfed till 6 months of age. And at 6 months, complementary feeding was started with ragi with no history of any altered bowel habits, vomiting, or food intolerance. No known food allergies, and now he has a mixed diet and has everything from consumes everything from the family board. And on assessing his calorie protein intake, he had an intake of 2,600 kilocalories as against an expected of 3,320 kilocalories with a calorie deficit of 720. And the protein intake was 65 gram against an expected of 61.5. Immunization, he was immunized for age as per the national immunization schedule, and the BCG scar was seen on the left upper arm. And the last vaccination was at 15 years of age. The discussed vaccines were not taken. And the developmental history, all milestones in the motor, language, personal, social, and cognitive domains were attained age appropriately. And now he studies in 12th standard with an average academic performance and active in sports. Family history. He is the firstborn of a non-consanguineous marriage with a younger sibling who is an 11-year-old male. Mother had a history of jaundice 1 year back and some oral medications were given and the jaundice had resolved, but the details were currently unavailable with the father. And no history of any chronic liver diseases, unexplained infant or sibling deaths or neuropsychiatric diseases in the family. No history of tuberculosis, bleeding disorders, genetic or developmental diseases, rheumatoid or thyroid disorders in the family. Socioeconomic status. Father studied up to 12th, now working as an electrician in Dubai, and mother studied up to 12th and now a homemaker. According to modified Kuppuswamy scale 2022, the family comes under class 3, that is lower middle class family, living in a single storied house with good sanitation facilities and no overcrowding. So summarizing
I think hold it, Silpa, you can go back to the first slide.
Yes, madam.
I'll start. So before starting, I think let me thank all the IAP officials for including me or inviting me as a faculty for this excellent teaching program. IAP Kerala, as well as in tune with the IAP Trivandrum, is, I think, excelling in all their academic activities, which exactly, especially, I think, are very beneficial for the postgraduates. But as already mentioned, how far they are using it, I don't know. Anyway, back to this. So, Silpa, just summarize the present complaints.
So, madam, this is a 16-year-old adolescent male who had presented with a history of persisting fever for 10 days with a yellowish discoloration of eyes, palms, and soles for the last 7 days, along with other constitutional symptoms like anorexia, malaise, abdominal pain, multiple episodes of vomiting, decreased urine output, frontal headache, and occasional dry cough. And he was the firstborn of a non-consanguineous marriage with no significant birth history pertaining to a present illness.
Hold it. We'll just analyze the presenting complaints. We just analyze the presenting complaints, and how are you going to explain this relationship with the fever and the jaundice? What do you think is the cause of jaundice? Means at the initial visit, not taking into further.
Initial visit in our hospital, madam.
Yeah, I know the initial history. Suppose the child has come to you with a fever of 10 days duration and a jaundice of 7 days duration, abdominal pain and vomiting of 4 days duration. These are the initial complaints, no?
Yes.
So, what do you think is the reason? Suppose the child had come to you for the first time.
So since it is a fever lasting for 10 days, it's a case of a persisting fever. And since there is a yellowish discoloration of eyes, palms, and soles with abdominal pain and vomiting, it more likely points to a pathology with the gastrointestinal tract, or more specifically some pathology associated with the liver.
So jaundice means it can be either a hepatic cause or a hemolytic cause.
Yes,
could you rule out a hemolytic jaundice here? From the history, how do you rule out whether it is a hemolytic or whether it is a hepatic or hepatocellular or obstructive?
Mainly the two basic questions we ask is the color of the urine and the color of the stools, madam.
How do you differentiate from the color of the urine and color?
If the color of the urine is normal, it's more likely to be an unconjugated or a hemolytic jaundice. And if the urine is high colored, then the next question should be about the stool color. So if the stool color is normal, it points to a hepatocellular injury. But if the stool color is pale, it points to a cholestatic cause.
Okay. So based on that questions, what do you think this child has?
Like when we took the history, the parents were telling about a high colored urine, madam.
Okay.
And
the high colored stool and the stools are
normal in color only.
No. What do you mean by high colored urine?
A dark yellow urine, which can be due to increased urobilinogen pigment.
Normal than it's slightly higher than the normal color, right?
Yes.
Okay. What are the other causes of a high colored urine?
Dehydration.
That's a concentrated urine. Okay, right?
Then drug intake like rifampicin, quinacridine.
Okay. Do you get a high cola-colored urine with this history? Can you get?
In case of associated renal involvement.
Without really an renal involvement. Okay, I think we'll come to that later. So you think it's mainly a hepatic jaundice, right?
Yes, madam.
And you think more of a hepatocellular rather than an obstructive, right?
Yes.
Okay. Now, based on that, what do you think is the cause? With the available information.
with the present history, since fever is also present, I would first like to consider the common infective causes for hepatic involvement, like an acute hepatitis, acute
Okay.
infective hepatitis.
Mm.
Then which can be either bacterial causes like enteric fever, leptospirosis, brucellosis, or it can be viral infections like the common acute viral hepatitis.
Okay, with this available history, what you have described, or by the relationship between the fever and the jaundice, how do you explain?
Fever is persisting even with the appearance of jaundice and other symptoms. I would like to think of a bacterial.
Or otherwise, I'll put it in a different way. What will be the relationship between the fever and the jaundice in the case of an acute viral hepatitis, like hepatotropic viruses, or as you said, in a bacterial infection, but not exactly bacterial. Will they typically leptospirosis? I think I'll ask someone else. Lamis, are you there?
Yes, ma'am.
Lamis, can you explain that is the difference in the history between sort of acute viral hepatitis, which also presents with fever and jaundice, and the leptospirosis, which also presents with fever and jaundice, from the history, initial points?
Actually, in viral hepatitis, by the appearance of jaundice, fever will disappear.
By the appearance, or can you put it in a little more better way? You're right. You're right. Usually there will be a prodrome. There will be a prodrome.
Yes.
What are the features of the prodrome?
Anorexia.
Yeah. Correct.
Then
Anorexia, nausea, vomiting, and
vomiting.
low grade. And the fever is not that high grade. Right?
Yes.
Here, how do you describe the fever, Silpa?
Kind of high grade intermittent fever.
So the fever is usually low grade. And as she said, after say 1 or 1.5, say 1 to 2 weeks of fever and only the jaundice appears. But here the relationship between the fever and the jaundice is, it's a high grade fever. And on the 3rd day of the fever, according to here history, 3rd day of the fever, child started having jaundice also. So it is unlikely to be from the history. This looks unlikely to be a just acute viral hepatitis. Okay. And can you think of any other infection which manifests with fever and jaundice? Lamis again.
And leptospirosis.
What is the relationship? What is the degree of fever and when does the jaundice appear? Yes.
Fever will be high grade in leptospirosis, madam.
Right. As in this case. But when do you get the jaundice in the case of leptospirosis? Typical description.
The immune phase, madam.
So what will be the initial period? How do you describe the initial period and then what happens?
The initial period will be the septicemic period where there would be high grade fever with the constitutional symptoms of anorexia, malaise, nausea, vomiting, or frontal or occipital, temporal headache and occasional dry cough, which will last for about 3 to 7 days. And usually, typically lepto has a biphasic course. That is following the initial septic phase, there would be a period of febrile period, which would be followed by the second immune phase, where there would be reappearance of the fever along with jaundice, hepatorenal impairment, thrombocytopenia.
So the jaundice usually occurs in the second phase or immune phase. But here I think in your history, there's no typical description of biphasic fever. Can you tell me a few other conditions where you get a biphasic fever?
Dengue fever.
Dengue fever you get, right?
Then other relapsing fevers like Pellepstein fever, Hodgkin.
Generally, what is the basis of this biphasic fever?
I'm sorry, I didn't get the question.
What is the reason? Why this leptospirosis, you said it is mainly an immunological. So most of the conditions make it an immunological. Any other explanation, any other mechanism by which fever can be biphasic apart from the immunological?
In the initial period, when the pathogen is in the bloodstream, it can cause the release of endogenous pyrogens, which can be responsible for the first phase of fever. And in the second phase in lepto, the pathogen gets colonized to the tissues and the body fluids.
No, Silpa, I was asking just about general. What is the reason for the biphasic fever? One, of course, is the immunological phenomenon, as typical you get in a leptospirosis. But can you think of any other condition where you get initially there is a fever and then that the fever subsides after 2 or 3 days, again the child gets a fever? Simple logic, simple. It is not, or it's not complicated, that's what I'm going to say, but it is maybe the complication of the presenting illness. Got it? That is initial, be it a viral or bacterial infection, and the infection tend to improve, and after that the child may go in for another complication where you get fever, biphasic fever. Typical examples. Say for example, in so there are so many viral infections which are complicated by HLH. What is HLH?
Hemophagocytic lymphohistiocyte.
Okay, that typical example is a dengue, or even a simple viral hepatitis can get complicated with HLH. What will be the presentation? Initially, the typical presentation of the illness, and then some febrile period, then you get another febrile. So there are so many reasons for a biphasic. Okay, just I think we are slightly deviating from that. So infection, among the infection, leptospirosis, can you think of any other infection which manifests with high fever and jaundice? That also you have to consider in the history.
Other bacterial infections like brucellosis, madam.
Brucellosis can manifest with jaundice, but it's much more commoner than brucellosis. But maybe it's not that common in our part of the state. If you go to North India or even Tamil Nadu, you'll get
Malaria.
Malaria. Did you say malaria?
Yes.
Yeah, malaria. Somebody had said. Then what will be the relationship between? What is the reason for jaundice in malaria? What is the reason for jaundice in malaria? What is the relationship between fever? That is how you analyze when you have fever and jaundice and then abdominal pain and vomiting.
In malaria, it would be a relapsing fever, tertian quaternion fever.
No, the question is, why is it? Yeah, I got answer from Neo, hepatopathy. Is that the only reason, hepatopathy? You get 2 types of jaundice in malaria. Yeah, from Abhinaya, I think hemolysis. So these are the 2 mechanisms by which you get jaundice in malaria. One is hemolysis and the other is a hepatopathy. So what do you mean by a hepatopathy? That means there is not much of a significant destruction to the hepatocytes in the case of malaria. It may be due to the other mechanism. So that is why we said rather than using the terminology hepatitis, it's better to use the terminology hepatopathy. And one other reason is the typical hemolysis. That is what we think, right? If it is due to a hemolysis in the case of malaria, what will be the clinical clue?
Pallor.
Yeah, it's usually associated with pallor. And one more thing.
Splenomegaly.
No. Yes, still in the history. Then in the history.
Bleeding manifest.
Yeah, somebody had written it's a hematuria. So better terminology, anesthesia, it is a hemoglobinuria, right? And what type of hemoglobinuria? It's an intravascular hemoglobinuria. So what will be the history you'll be getting? Intravascular hemoglobin. Intravascular hemolysis, it will lead to a hemoglobinuria. So what will be the history? You'll get a what?
Pink color.
Pink color.
Red color.
It's not exactly red. It comes as sort of a
Cola color.
Cola colored or a smoky colored urine, right? So if you have fever, if you have jaundice, and if you have a cola colored or a dark urine, it's intravascular hemolysis. And of course, smoky urine, I think I'm getting answers good. either but mostly an intravascular hemolysis. So you have to say that the jaundice in a case of malaria, it may be due to the hemolysis, but mind you that intravascular hemolysis and hemoglobinuria, there will not be much of a jaundice. There will not be much of a jaundice, right? Okay. Any other condition may have a fever and jaundice? Fever, jaundice, and like this in your provisional diagnosis.
In
Abscess, Kailas. But anyway, Kailas is not this typical history. I think you'll just forget about Epstein-Barr virus. But I'll go back to the initial answer. Somebody had said liver abscess. But mind you one thing, the liver abscess is quite localized, right? Whereas hepatitis, whatever it is, it's a viral hepatitis or leptospirosis, it is an inflammation of the whole liver. So for a child or adult to manifest with jaundice, there should be at least a minimum 70 to 80% of the loss of the hepatocytes. It should be a widespread injury for that to clinically manifest with jaundice, whereas the liver abscess, it's quite localized. So only the hepatocyte that particular area is damaged. So that may not lead to jaundice. That may lead to a very high fever, but jaundice is not that predominant. Somebody had written liver abscess, that is why I did. So liver abscess generally do not produce jaundice for the reason I have mentioned. For you to have a jaundice, I think majority of the hepatocyte have to be injured. That will happen only in sort of a widespread injury like a disseminated infection and all. Okay, right. Okay, any other thing? Now go to the next slide.
Just a query, madam.
Yeah, I'm sorry, I totally forgot here this thing.
No problem.
Where you want to contribute? Yeah.
Just it would be good if she gives us some more details about the abdominal pain, because somebody has with fever and jaundice, apart from the acute infective settings, we can also think about a possibility of, especially in an adolescent boy, we can also think about a possibility of a cholangitis. It could be the first sitting of a choledochal cyst, rare possibility of a gallstone disease, which could also present like a, so as you said, the hemolytic part, the hepatocellular part, we've already discussed the infective, but there is a third column which the abdominal pain would actually give us the clue to if it is an obstructive component or obstructive cause for the fever and jaundice. If they would have typically a localizing type of right-sided abdominal pain, fever with chills, there we can think about a possibility, because as we are thinking wide and as we are, our syndromic diagnosis is a fever with plus jaundice. So we could also think about the possibility of an obstructive jaundice, keeping in mind the possibility of choledochal cyst with cholangitis or gallstone disease with cholangitis. And rarely liver abscess can also present if the abscess ruptures into the biliary system and cause jaundice. But otherwise, as you said, liver abscess per se, the first or the most common presentation is fever and pain, and jaundice is rarely, very rare in that setting.
So if it is a choledochal cyst or a cholelithiasis, one point in the history, what is that can definitely rule out, Silpa? We already mentioned that.
Features of cholestasis, madam.
Yeah, right. Okay, now go ahead with the next slide. Pale stools, right? I think this is all we have. Moving on to the negative history. Negative. You said there is a high colored urine, but no pale color. That's okay. Melena, hematemesis. Why did you go for a history of a facial puffiness, pedal edema, and abdominal distension?
Madam, to look for facial, in case of any associated hepatorenal impairment, to look for facial puffiness, then also liver diseases can be associated with hypoalbuminemia and ascites, chronic liver disease.
Okay. And the next sentence is mainly for a failure. Liver cell failure disturbance. Okay, right. And history of playing football in the nearby field. That's okay. What is the relevance? What is the relevance of that history? How are you going to explain? And the Maya?
I think she also want to keep the possibility of Wilson's in mind. I think that's why she has kept that underlying liver disease Possibly that's why she's included that scholastic performance, abnormal movements, isn't it, Silpa?
Yes, madam.
But other to say in common sentence library. Same sentence, you should have split it into two. Because
yes.
sleep distances, altered sleep pattern, and behavioral changes which suggest a chronic liver disease with a liver cell failure, and decreased scholastic performance, abnormal movements. You put it as a separate sentence so that you want to rule out a chronic disease, especially Wilson. Then that would have been clear to know.
Okay.
What is the relevance of history of playing football in the nearby fields?
A history of contact with contaminated environment as suspecting leptospirosis.
Contaminated with what?
With the urine of infected rodents.
Okay. And the next, why do you want to say any rashes and what type of rash?
In leptospirosis, a few cases can have a transient erythematous rash developing in the initial septicemic phase of the leptospirosis, and also in case of for other conditions like malaria.
Do you get otherwise any type of rash in lepto second phase?
Bleeding.
What is the full name of that second phase?
Leptospiruric phase.
What is the other name?
Phase.
What is the other name for that second phase? Beale's disease. Can you explain to one more? Beale's, any other term? Right, Beale's disease. It is ictero. Ictero.
Hemorrhagia.
Hemorrhagica, icterohemorrhagica. So you definitely will be getting some evidence of
bleeding.
The icterohemorrhagica. That means you'll get some evidence of a bleed, right? Okay, that also you look for it in the second phase. Good. Okay, right. Then, yes, specifically said that the herbal and indigenous medicine, exotic foods. Otherwise, drugs which are commonly used by we people. Have you heard of any DILI, drug-induced liver injury?
Yes, madam. Like
especially the child has got a high fever and the child has received some drugs. Which drugs can induce a liver injury which can manifest with jaundice?
High doses of paracetamol.
Yes. Then
erythromycin group of antibiotics, sulfonamides.
But before that, sulfonamides and all we are not using nowadays, no?
NSAIDs.
NSAID is okay, but other than that, anticonvulsants.
Anticonvulsants.
Which anticonvulsants?
Phenytoin.
Much more than that, hepatotoxicity. Valproate. Any anti-tuberculous drug. Right. So these are the drugs rather than, okay, right. Somebody had written SVP. What is SVP? Sodium valproate maybe. Okay, right. INH, anti-tuberculous drug. Then you have no history of similar illness in the close contact. Similar illness means?
Case of fever with jaundice, like to suggestive of acute viral hepatitis A.
Okay. What is the relevance of the next sentence? That is, do you really think a TB can cause a clinical picture like this?
A very less chance, like in a disseminated TB with a lymph node pressing onto the.
Maya had opinion on the TB, hepatic tuberculosis. Can it really manifest with jaundice?
They usually don't present with jaundice. Actually, they would sometimes, many times, the fever history also we would not get. They would be just having the liver lesions with LFT alterations more or less and very close. So the history with this kind of high grade fever per se tuberculosis is less likely, but we cannot say, we cannot exclude
No, for that matter, anything can happen in medicine.
But it's very less likely.
That is different, but generally a hepatic TB do not manifest with this clinical picture.
Correct.
Okay, Silpa. Okay, the next slide. What is the importance of no history of similar episodes in the past? Means recurrent jaundice. Which condition you get a recurrent jaundice?
Madam, in familial jaundice conditions which can be precipitated by intercurrent infections, there
Like,
can. Madam, sorry.
like example?
Like Gilbert syndrome, then curricular nausea.
Okay, but much more common than Gilbert's. If you are asked what are the narrate causes of recurrent jaundice other than Gilbert's, yeah, somebody had written hemolytic anemias. Typically, which hemolytic anemia manifests with recurrent episodes of jaundice?
G6PD.
G6PD, how many G6PD are seen? Which is the other hemolytic anemia? Spherocytosis, no? Hereditary spherocytosis, HS spherocytosis, right? Then no history of recent. Okay, what is that?
With relevance to this case, madam, what she said, like history of recurrent episodes in the jaundice, of jaundice in the past, I don't think Gilbert's is what I would keep in mind. I would keep possibility of an underlying autoimmune disease or an underlying Wilson's, which was probably diagnosed as an acute hepatitis, acute viral hepatitis, and now presenting probably with a second or third episode of jaundice with an underlying chronic liver disease. That would be in
Basically.
this setting, when you have a similar history of jaundice in the past, that would be something I would keep in mind.
Okay, that second negative history, no history of recent hospital admissions, surgeries, and blood transfusions, all for?
Hepatitis B.
Okay, which is the hepatitis which is most commonly spread by blood transfusion?
Hepatitis C, madam.
Hepatitis C, good. He's not on a regular medication, right? No history of allergy, any addictions, drug usage, tattooing, etc. Okay, continue with that. There is nothing contributory, right? Okay, you can skip that.
No.
Diet, okay, right. Immunization, I think it is better that you would have mentioned something else also. Mention some other. What do you mean by discussed vaccine? Are you using that terminology for the optional vaccines?
Yes, madam. So regarding special mention regarding whether hepatitis A vaccine was taken or not.
Yeah, right. That's very important, whether hepatitis A vaccine taken and hepatitis, because 16 years for the child has taken hepatitis B also. I think by that time hepatitis B was
also
there.
is important, equally important.
Equally important. Most probably they would have taken, but still make sure that the child had taken hepatitis B as well as the hepatitis A vaccine. Okay. Then the developmental history. Okay, right. The family history, what all things? Why do you want to ask for a consanguinity?
Consanguineous marriage can result in precipitation of autosomal recessive conditions like Wilson's disease.
Okay, main thing is, as far as in this context, I think one is Wilson's disease. Okay, right, then
the familial jaundice conditions like Gilbert and all are also autosomal recessive.
Gilbert's generally we don't consider as a very significant DD at all. No, it's not considered. What else?
She's very fond of Gilbert's.
Yeah, so
why do you think this jaundice is related to Gilbert's, Silpa? There's nothing in the history or so far that is a pointer to Gilbert's. So what is when do you suspect Gilbert's? Just the word. What is the situation when you suspect Gilbert's in a child?
Usually detected incidentally during a routine checkup when only the total serum bilirubin is elevated with a normal LFT. Normal liver enzymes, bilirubin high, the fluctuating bilirubin, and what is the type of jaundice? What is the type? Unconjugated hyperbilirubinemia. So that is something which at presently we don't consider, because you also said urine is yellow. So we are also thinking about a conjugated, possibly a hepatocellular and a rare possibility of an obstructive jaundice. So I think Gilbert's doesn't come into this preview at all.
You yourself have committed that it is a hepatocellular jaundice, right?
Yes.
Right. So the mother, is there any relevance regarding the history of jaundice for the mother? And do you think of? So can you think of any relevance here in this particular case, or can just take it casually that she had a viral hepatitis again?
Some odd.
What somebody had written spherocytosis. Okay, but here again, we're thinking only of now, I think back to hepatocellular type of jaundice, so that may not be relevant here. Okay, the third is hepatitis A, that is unrelated because of the same epidemiological factors, social factors. Okay, like, and the history of a chronic liver disorder. But you did not mention, okay. You said no history of any chronic liver disorder or a sibling death or a neuropsychiatric disease in the family, obviously for a
Wilson's disease.
okay, so what are the means by which the Wilson's disease can manifest? What are the different presentations?
It can either manifest in the as the neuropsychiatric manifestations of
Tell
anxiety.
the common things first.
Commonly, it being a metabolic disorder, it manifests with KF rings in the eyes.
Is that the common presentation? Okay, you just divide it into hepatic and a neuropsychiatric. Of course, agree the child is 60 years, they can have a neurological manifestation, but what are the primarily we are discussing a hepatic, right? So what are the different types of hepatic manifestations of a Wilson's, and then you can say what are the neurological manifestations. What are the hepatic manifestations?
Coombs neck.
Okay, I think less common you're saying first. Okay, Coombs.
Coombs negative hemolytic anemia.
Yeah, it may be Coombs negative hemolytic anemia, and much more commoner than that.
It can manifest as a chronic liver disease or in failure or.
So you don't want to consider a Wilson's here as a DD? No or S?
Yes, ma'am.
Why?
Because of the.
What is the presentation here?
Fever with the early onset of jaundice.
This is the presentation of an acute hepatitis, right? So a Wilson can present as an acute hepatitis or a
Chronic liver disease.
or
in acute liver failure.
okay, and then it can manifest with a hemolytic anemia also, or the neuropsychiatric manifestations. Maya, want to take up from here different manifestation?
Starts with an enlarged liver, asymptomatic hepatomegaly to mildly altered liver enzymes to acute hepatitis-like presentations, chronic liver disease, which may present with an acute presentation. Like, for example, this child may fit into that. The child may be having a chronic liver disease for a long time. And now with some acute insult, we don't know what the child has presented with the. Otherwise, it's difficult to explain the fever part. So there's some acute insult, like some infective cause which is precipitated this, and the child has presented with an acute, we call it as acute on chronic presentation, or it could be a fulminant hepatic-like presentation. Coombs negative hemolytic anemia. Again, in this child, I think we should also keep that in mind because there was a history of two transfusions earlier. Which I think she mentioned. So these are some of the pointers telling us that we should keep our eyes open, not just for an acute presentation. There could be an underlying chronic problem. Apart from this, the neurological multiple presentations of CNS manifestations, renal presentations can sometimes be there.
Silpa, so it can be the acute manifestation of an underlying chronic liver disease, as Maya had mentioned. But did you mention anything in the history regarding the chronic liver disease? Or otherwise, can you just repeat it? What are the points in the history that will be eliciting for a chronic liver disease?
In a patient with chronic liver disease, there can be failure to thrive.
Grow, okay, right, 16 years.
Then endocrine issues like gynecomastia, testicular atrophy. And other skin and nail changes can be seen. And history of a delayed puberty.
Okay, what are the other features? Growth failure, that's the other thing. Any other? features of generally pruritus. Okay, somebody had written pruritus. Pruritus is typically a cholestasis. Jaundice, yes, jaundice obviously there. Abdominal distension, edema, bleeding tendency. All these are the features of a chronic. So in the history also, I think you have to mention whether there is any history suggestive. We are mainly talking about the history suggestive of a chronic liver disease. Failure to grow means failure to grow. There's a growth failure, not the endocrine, but on the whole, they'll be short and they'll not be gaining weight and all. The child has got a chronic liver disease. On the top of that, there will be other features. Okay, what is the relevance of this? The last para, that is no history of TB again. Okay, that you can forget about. Bleeding disorders. Why do you want to say bleeding disorders?
Hemolytic.
Hemolytic is a bleeding disorder. Hemolysis manifests with bleeding, right? No. Which, no, whenever, whatever you say, you should have a rationale for each negative point. Why do you want to say no history of any rheumatoid or a thyroid disorders in the family?
Autoimmune.
That's very important. Autoimmune hepatitis. And that can also manifest with sort of a chronic with intermittent relapses. That is what I had been mentioning earlier. Okay, but this is a 16-year-old. What are the two types of autoimmune hepatitis and which one fits in with this?
Type 1 and 2, madam.
Yeah.
Type 1, type 2 is the more severe form. And in autoimmune, there is usually a female preponderance.
What percentage usually? What is the percentage? Female to male? Just an average. Around about number.
If you know, you can answer, otherwise.
2/3 to 1/3. 2/3 is more than 2/3 would be female, but there would still be a 1/3 of children who could be autoimmune. And how do you differentiate between type 1 and type 2? That's what madam is asking. Especially in this case, what is the age of presentation? This is an adolescent boy. So what do you suspect? Is it type 1 or type 2?
Type 2 occurs more in older children and adolescents.
No, it's the other way around. Type 2 is in more younger children. It can even be seen in infants, whereas type 1, it can be any age, including adolescent age.
Okay. Go ahead. Next. So how have you, next slide? Next. So you have summarized this as?
16-year-old adolescent male with normal developmental history and adequately immunized for age, first born out of non-consanguineous marriage, presenting with complaints of persistent fever since 10 days, associated with progressively increasing jaundice, myalgia, abdominal pain, nausea, vomiting, malaise, anorexia, and headache. History of being admitted and treated in nearby hospital with IV medications and blood product transfusion. Now referred to our hospital for detailed evaluation and management for a persisting jaundice. No other significant history contributory to the present illness.
Summary means you need to sell only the points which help you to make a diagnosis, right? Everything again, it's not a summary. Okay, the last para and all you can just put. Okay, next. So what do you think? What are the possibilities from the history book?
So from the history, I would like to consider infectious causes first. Which can be acute viral hepatitis, leptospirosis, then scrub typhus.
Don't say the textbook diagnosis, this particular case. Still, you want to consider an acute viral hepatitis?
No, madam. Leptospirosis.
So prioritize, right? Infectious causes, which one you want to say? So I think it may be lepto. Then?
Wheals disease, then scrub typhus.
Scrub. Then? Only two? Yes, so discussing. Do you want to bring in a possibility of a Wilson also?
To rule out an underlying metabolic cause like Wilson's disease.
Okay. Anything else?
And, autoimmune.
Autoimmune also. Any child, older child coming with jaundice, I think I'd rule out an autoimmune. So I think it's almost from a history by the reasons we have said, I think you can rule out acute viral hepatitis mainly because of the relationship with fever and all. Then among the leptospirosis, and why do you want to bring in a scrub typhus here? What are the points in the history?
Fever, which is lasting more than 7 days with constitutional symptoms, and jaundice is also possible in a case of scrub typhus.
But how common is jaundice in scrub typhus?
Rare, madam.
It's not that common. So I think after your complete history, I think still there are so many, what are the points in favor of making a diagnosis of leptospirosis other than the constitutional symptoms we have described? Anything else here?
Yeah. The playing in the nearby fields.
Yeah, right. Anything else?
Then
Is there something else in the history? Apart from the constitutional symptoms and the playing, and what happened? What is the course?
he was given blood product transfusion. And still his fever and jaundice was persisting with increasing myalgia.
Yeah, somebody had written there is a reddish high colored urine, no? There is a hematuria, right? Yes. So that all is a point in favor of considering a leptospirosis. So I think among the infections, leptospirosis you can consider rather than an acute viral hepatitis, or Wilson's definitely. An older child with a jaundice, you have to rule out a Wilson. I think autoimmune hepatitis also. Anything else, Maya, from the history?
Where these are the common ones now. Acute infections, leptospira, malaria, we said that still, especially from Tamil Nadu, we should keep in mind. In acute viral hepatitis, sometimes can be a possibility if you have a co-infection, because especially when you have an enteric fever, they sometimes we have had few cases like that where they have both co-infection with the enteric fever with acute viral hepatitis.
Yeah, infections among the infections, I think bacterial enteric also, even though it's not that common, as you said, they can coexist with even viral hepatitis or a lepto, both.
Correct.
Because of the same. Now, what is the mode of transmission? You said is a contaminated water. So the same thing, contaminated water can lead on to an enteric infections also. Okay, go ahead. Now we'll go ahead with the physical examination.
So general examination, he was conscious and oriented. Icterus was noted. In his vitals, temperature was 100.6 degree Fahrenheit, and the pulse rate was noted to be 58 per minute with a regular rhythm, normal volume and character, and no radiofemoral delay. Respiratory rate was 18 per minute, regular, thoraco-abdominal with a normal work of breathing. Blood pressure was 110/70 millimeters of mercury in the right upper limb. Saturation was 98% in the room air with a capillary refill of less than 3 seconds, and the GRVS at admission was 98 milligram per deciliter. Then head to foot examination. There was no dysmorphic facies, microcephaly, vitiligo or seborrheic dermatitis noted. In the eyes, icterus was seen. No evidence of any conjunctival suffusion, visible cataracts or bleeds. Ears were normal. Oral cavity, lips were dry. No ulcers or bleeds. Tongue was moist. No fetor hepaticus. No teeth discoloration. In the chest and abdomen, no gynecomastia, spider nevi, bleeding manifestations, scratch marks, no abdominal distension, and umbilicus was normal and central. In the upper limb, again, icterus was noted on the palms, no palmar erythema, tremors, or nail changes. Limbs, icterus was noted on the soles of the feet, no joint swellings and no pedal edema. Genitalia, normal male genitalia with no testicular atrophy, Tanner stage 4. Spine was normal with no bony deformities noted, and no lymphadenopathy, scratch marks, tattoo marks, or bleeding manifestations noted on the head to foot examination. So this was the picture of the drawing. With visible icterus, which can be noted on the sclera and the palms.
Okay.
Then in the anthropometry, his observed weight was 58 kg against an expected
of normal, no? I
normal,
think
normal.
Skip that.
Then in the systemic examination, gastrointestinal system, in the upper GIT on inspection, lips were dry, oral cavity, tongue was moist with no ulcers or bleeds and no fetor hepaticus, and throat was normal. Lower GIT on inspection, no spider nevi, bleeding manifestations, scratch marks or rashes, no abdominal distension. All quadrants of abdomen were moving equally with respiration. No dilated veins, scars, sinuses or visible pulsations, and umbilicus was normal. On palpation, the abdomen was soft, no palpable pulsations, no ascites. There was a mild diffuse tenderness noted over the right hypochondrial area, and the liver was palpable 2 centimeters below the right costal margin, soft, smooth with regular, smooth and regular surface. Spleen was not palpable. On percussion, a normal resonant note was heard and no shifting dullness or fluid thrill elicited. Liver span was found to be 12 centimeters. On auscultation, normal bowel sounds were heard and no bruit auscultated. Other systemic examinations in the cardiovascular system, on inspection, inspection findings were normal for the cardiovascular system. On palpation, the pulse rate was found to be 58 per minute with a regular rhythm, normal volume and character, no radiofemoral delay, and apex was felt in the left fifth intercostal space 1 centimeter medial to mid-clavicular line, no cardiomegaly. And on auscultation, both S1, S2 were heard. There were no muffling of heart sounds, no murmurs or gallop. And in the central nervous system also, he was conscious oriented with a normal memory, speech and gait. The other CNS components were normal. No asterixis was noted. Pupils were equal and bilaterally reactive to light. No neck rigidity or no spine deformities. And respiratory system was also within normal limits, madam.
Okay.
So the
Just before you go for the summary, I think go back to that. Normally, when the child has got a temperature of 100.6, what should be the pulse rate?
Madam, for every 1 degree Celsius or 1.8 degree Fahrenheit rise in temperature, there would be an increase in pulse rate by 10 beats per minute.
Okay, so how are you going to explain this bradycardia here?
This comparing the temperature, it's a relative bradycardia, which can be seen in cases like lepto and enteric fever, or the bradycardia can be due to the jaundice, like cholestate, bile salts in case of jaundice can cause SA nodal.
Which jaundice? Which jaundice?
Cholestatic jaundice.
Yeah, obstructive type of jaundice similarly. Other than that, cannot produce a bradycardia. Okay. Yeah, somebody had written something else. In which condition you get a relative bradycardia? Somebody had written a dengue. But which phase of dengue you get a bradycardia? Which phase of dengue? It is the recovery phase. Recovery phase. Okay, or it may be resolving. Somebody had written. Resolving or recovering phase. Other than that, here, if you consider the diagnosis of, just forget about the obstructive jaundice, relative bradycardia, you get typically in enteric and leptospirosis, or it may be a myocarditis. Is there any complication? That can also think of that. But otherwise, the child is okay, no? Okay, next slide. Apart from the icterus,
No one.
okay, specifically, what is the relevance of this dysmorphic facies, microcephaly, vitiligo? No, you had said in a 60-year-old child. What do you have in your mind?
Some
Dysmorphic facies?
inborn errors.
You don't consider the possibility of an inborn error of metabolism for this child, no? The negative points also should convey some meaning. So I think these are not irrelevant negative points. Negative points, you just minimum negative point, but that should convey some message. Microcephaly also no. But chronic hemolysis, we don't consider here as a DD at all. But vitiligo, maybe I'll say yes. Why? Why did you say vitiligo has a negative point here? Autoimmune. Yeah, somebody had written autoimmune. So autoimmune hepatitis, there may be other manifestation like conjunctival suffusion.
Leptospirosis.
Leptospira. Subconjunctival bleed also.
Leptospira.
Leptospira. Cataract. Which condition you get a cataract? This type of clinical picture.
Wilson's disease.
Wilson's disease. How do you describe the cataract in Wilson?
Sunflower cataract.
Sunflower cataract. Okay, right. Ears normal. Oral cavity. No ulcers. Okay, right. The last part is gynecomastia, spider neve, and all you already said chronic liver disease. Okay, right. Next.
Why
Next.
why did you not mention carefree in your eye examination?
Yes,
Yes.
ma'am. Yes.
You considered Wilson's in your differential,
Ah,
so you should look for it, right?
yes, ma'am. Missed it.
Especially a 16-year-old child, I think you have to look for. What is the reason for the carefree?
Excess copper deposition in the Descemet's membrane of the cornea.
Okay. It's always visible with the naked eye examination.
Slit lamp examination.
You can try for the naked eye examination, and if not, you can go for a slit lamp examination. Okay, go ahead. The next.
If the KF ring is negative, does that rule out Wilson's in this
No,
child?
ma'am.
Even if you have a negative KF ring, in slit lamp examination, does it rule out Wilson's?
No, madam. Because carefree
why?
can be seen only in 25 to 30% cases of Wilson's.
Okay.
Yeah, to 50% of patients may have, but neuro Wilson's, it would be 100%.
What are the other conditions where you get a carefree? Can any other condition get it?
She already mentioned it for some other differential.
Chalcosis. But that's very rare here. Any other? Yeah, prolonged cholestasis. Somebody had it. Prolonged cholestasis. Okay, now the icterus. SMR, spine normal, no lymphadenopathy, no scratch marks. That's again for a cholestasis, right? Bleeding manifestation is very important for you to say. Go ahead. Okay, go ahead. What your abdomen finding is mainly diffuse tenderness and liver palpable 2 centimeter. And the liver span you said is a 12 centimeter. So what is your inference from that? A span of 12 centimeter? Is there a hepatomegaly? Or it's a normal liver?
Upper limit of normal only, madam.
What is the normal liver span in a 16-year-old?
Around 10 to 12 centimeters.
12 centimeters. So that means there's no significant hepatomegaly, right? But it is tender.
10. Other systems were normal only.
Okay. Which other system specifically you look for?
Cardiovascular system to look for any myocarditis.
Okay. Respiratory system, anything will you look for?
Any features of ARDS, pulmonary hemorrhage.
ARDS, pleural effusion can get, and then somebody said CNS. Okay, that is for neurological. So after having a complete examination, have you become wiser, or what do you want to change up the priorities of your differential diagnosis?
I would first like to go with leptospirosis itself, ma'am, in view of this fever, jaundice with a relative bradycardia.
Now just concentrate on the physical findings. Summary, history we already summarized. So what is there in the physical findings which point to a diagnosis of a lepto here?
One, a relative bradycardia. Then tenderness.
That's not a very strong point in favor.
Then tenderness over the right upper quadrant, which is suggestive of diffuse hepatic involvement.
You expect a hepatomegaly also. Why do you get a tenderness there?
The hepatitis, madam.
Hepatitis. How does that produce a tender liver?
Stretching.
Yeah, right.
The inflammation of the hepatocytes can cause stretching of the capsule.
This is mainly the stretch, because inflammation, it produces a little hepatomegaly, and that produces a stretching of the capsule, and that produces tenderness. Okay. But the spleen is not palpable.
Oh, no, madam.
But can you still rule out Wilson's?
Not necessarily. Wilson's can be a possibility.
Wilson's also still, I think with the investigation findings also, with the physical findings also, we cannot 100% rule out. Can you rule out a malaria here? Because you have considered the differential diagnosis malaria.
Splenomegaly.
Normally you expect a splenomegaly, so that is not there. You expect a pallor, that is not there. The only jaundice, the fever and the jaundice, but the physical findings is not there. Normal growth ruling out, with the normal growth, you cannot rule out Wilson, because sometimes it may manifest a little later also. So normal growth, 100% no. Still, we have to consider any older child or any child above the age of 5 or 6 years manifesting with jaundice. I think it is better to rule out Wilson's. But if you have other possibilities like viral hepatitis due to the heterotrophic viruses and all, okay, you can then consult with that. Okay. Maya, you want to add anything else in our differential diagnosis, or can you go for investigations?
Pretty much didn't change our differentials, but only thing is she said a soft liver is something which is slightly against underlying chronic liver disease possible. If you ask me, that is the only thing. Probably now I am thinking, though I did keep a possibility of underlying chronic liver disease, when she said the liver is soft to palpate, it's less likely that there could be a possibility of underlying chronic liver disease, but I would still keep that option, though down the list.
So what is Maya trying to tell that in a chronic liver disease, what will be the feel of the liver?
It would be more firm. You would find that the liver is more firm.
I was asking her. I was asking her. Okay, it should be more firm liver.
No,
rather
which
than,
you would be, it is easy to palpate. You just put your finger and you would feel the liver would. But then it need not be always like that, especially in the early, especially in a child. We may not get that firm feel like we get in older children or adults. So I would just say, if you have a very, very soft liver, which is tender, then the possibility that there is an underlying chronic liver disease is less likely. And but with all this, we would still keep the possibility or options open, so that we would, if the child is not improving, we would keep the possibility of a chronic underlying chronic liver disease still in mind.
Okay, now with this differential diagnosis, I think what are the investigations that you're going to do?
So first, I would like to do a complete blood count to look for the hemoglobin level. Then to see the trend of the total counts, whether it's leukocytosis or leukopenia, and also to see the platelet counts. Then ESR, we can also check the ESR, which can be increased in case of infectious conditions.
Can you move the slides also?
Yes. So this was actually
Go for the DD, this price slide. What all things you written?
So first I considered infections, madam. Weil's disease as the first.
This is like a theory exam you written. No, this is differential diagnosis should be relevant to our particular case. We have discussed so much, and after that, I think after a physical examination and all, persistent fever with jaundice with the history of a blood product. What do you think is the reason for a blood product transfusion here?
Since they had in the outside hospital, they were told that he had a liver disease. Probably they could have given FFP transfusion, or actually the blood counts, there could have been a thrombocytopenia. If we are considering lepto, there is a possibility of a transient thrombocytopenia. So it would have been a platelet transfusion. Okay.
So you think of an acute liver injury but acute hepatitis with no evidence of liver cell failure to other causes. So Weil's
differentiate if it was Paxil or white. You could just ask the patient, was it white blood which was given or was it red blood? Then they would, even if any illiterate person will tell you, this is what is Paxil transfusion or.
Did you ask?
Yes, madam.
What was that?
Platelet transfusion.
It was a platelet transfusion.
Okay.
Okay, I think again this differential diagnosis you should have narrowed down. I think drug induced, definitely there's no history of a definite drug. Metabolic Wilson's, but they are so fond of that Gilbert's. I think take away the Gilbert's. Collagen vascular disease. Which collagen vascular disease you want to consider here? Which one?
Juvenile idiopathic arthritis.
Juvenile?
Idiopathic arthritis.
JIA.
J.
Juvenile idiopathic arthritis. No, I think you have to take away all these. Maximum is autoimmune hepatitis. Wilson should come. First, I think Weil's disease, and then I think hepatitis and all. You can remove from this list now. Enteric also, scrub maybe, malaria also. I think you don't have a splenomegaly. The history is not very. So narrow down your differential diagnosis and then accordingly. This is the whole writing a theory exam. You have written everything. Anyway, what are the investigations?
This was the investigations that they had done at the outside hospital, ma'am, during that initial period of admission. So they're the
Okay, we can go back to the previous slide and tell us the investigation that you will do, and then we'll go that.
First, I'd like to check the hemoglobin, ma'am, to look whether there is an anemia or not.
Okay.
Then total count to see whether it's a leukocytosis or a leukocytopenia. And then at the platelet count, whether there is a thrombocytopenia that's happening along with this liver disease. Then I would like to check the liver function test, like to see the value of the total bilirubin as well as whether it is direct or indirect bilirubin that is elevated. Along with that, the transaminases values, AST and ALT. Then I would also like to check at the renal function test to see if there is any associated renal impairment along with this hepatic dysfunction. And
definitely
also,
this child needs, because you said there is a history of hematuria. So definitely you need a RFT. Okay, right then.
Then also to look at the synthetic functions of the liver, I would like to check the albumin globulin levels and also the coag profile, PT, PTTI.
Okay.
And also the specific serological test for lepto IgM, along with that scrub IgM and Vidal testing. And
do you really consider an enteric here after the examination?
no, ma'am. Lepto IgM I would first send.
That also you should order only the relevant investigation. Lepto IgM, it's okay. If you're so fond of scrub, it's okay. But no, Vidal and all here. Okay, then anything else?
Since I'm considering the possibility of Wilson's serum ceruloplasmin and 24-hour urinary.
But before that, I think definitely we have to go for, because again, there's a chronic disease, and on the top of that, an acute hepatitis. So definitely viral studies like hepatitis, viral hepatitis A, hepatitis B, and hepatitis C. That is definitely mandatory, right?
Then considering a possible autoimmune, we can look at the ANA and autoantibodies like anti-SMA.
Okay, then you have Wilson's. You didn't say anything about, because that has to come higher up.
Serum ceruloplasmin and 24-hour urinary copper, madam. And also an ophthalmological examination to really see whether there's a cave.
Slit lamp examination. Okay, right. Can you differentiate by doing a transaminases like STU and ASTPT or ALT and AST? What will be the picture like if it is a viral hepatitis, acute viral hepatitis, or if it is a lepto, or if it is an autoimmune hepatitis, or if it is a Wilson? Can you differentiate?
Both ALT and AST will be elevated, but ALT is a more specific marker for hepatic injury per se, while AST can be elevated in conditions involving the general, having a generalized involvement.
Okay, that's a great. ALT is more specific for liver, but the question is, in a viral hepatitis, in a leptospirosis, and in a Wilson, and in, because these are
more
the main
10 times the normal, madam.
Which one?
More than 10 times the normal, elevated more than 10 times the normal, or in
10 to 20 times normal in
acute viral hepatitis.
Acute viral hepatitis due to the hepatotropic viruses like A and all. Right, okay. What about lepto? Somebody had written at OT more in lepto. What does that mean? SDOT or IST, it's relatively more. Why? You know why? Explanation, you have said that.
Since it has other organ involvement, like there can be pulmonary hemorrhages, ARDS.
Much more than that. Severe myalgia, myositis, because this is the enzyme that is liberated from the muscles also, right? The muscle involvement that somebody had written that. Okay, right. So the AST will be more. What about, and what is the degree of elevation in lepto when compared to the acute viral hepatitis?
Around 5 times the upper limit of normal.
it is not as high as an acute viral hepatitis. What about autoimmune hepatitis? What will be the degree?
Thrice. Less than 3 times the upper limit of normal.
Autoimmune? No. What about Wilson's? So by doing this itself, we can say we should have an idea of how we are going. Maya can explain the different transaminases degree of elevation.
She said correctly, viral hepatitis, very high enzyme elevation. Autoimmune, sometimes you could have just mild elevation. Sometimes when they present like a chronic liver disease presentation, the liver enzymes may not be too high. But when sometimes they have an acute hepatic presentation, there you would still have very high liver levels of enzymes, like in thousands. Wilson's disease, again, it depends on what is the type of presentation. When you have an ALF presentation or the fulminant liver failure presentation, in that setting, you have the AST much higher than the ALT. So AST-ALT ratio is more than 2.2. And they would have an alkaline phosphatase, which is low. So ALP bilirubin ratio would also be less than 4. These are some of the tips which we take when they have an ALF presentation, especially because they have an associated hemolytic anemia. All this, you have there, what they say is you have an AST-ALT ratio more than 2.2 and an ALP bilirubin ratio of less than 4. This is almost very high sensitivity to say that the ALF is possibly due to Wilson's disease.
Okay, that's a very important point. That comparatively, the alkaline phosphatase levels are also low. The AST levels are very high. Okay. Okay, now we go for the, is that all investigation? Now you go for the results of this particular?
So these were the investigations that they had done.
Can I just put a one point? There is something called a seronegative autoimmune, where we find that you find very high immunoglobulin. So there are situations where you find that ANA and ASMA may be negative. So in such children, when we have a very high suspicion of autoimmune disease, along with, as you said, ANA and ASMA, would also do a total IgG levels to see whether there is hyper gamma globulin.
You may get a clue indirectly when doing a serum albumin globulin ratio also, that the globulin levels will be high. And that will be an indirect clue for us to look further for an autoimmune disease. Okay, yes. What happened to this?
At the outside hospital, when they had did the blood investigations on the successive days, it was noted that he had a progressive drop in the platelet counts. That is on the day of admission to the outside hospital, it was 20,000, which had dropped to 15,000 on the next day. So he was transfused with 2 units of platelet on the second day of admission there, and following which the platelet counts had increased. Then ESR was elevated, that is 110. And CRP, according to their cutoff, was also elevated, 7.4. The sodium and potassium levels were within normal limits, but the blood urea nitrogen and creatinine had showed elevation in values. And also in the urine routine examination, bile pigments and bile salts were detected. And when they had did the bilirubin analysis in the hospital, it was found that of the total elevated, of the elevated total bilirubin, majority was contributed by the direct bilirubin component or the conjugated hyperbilirubinemia. And on analyzing the transaminases, initially, even though the SGOT was elevated, on the successive days, SGPT was found to be increasing and decreasing, and SGOT was found to decrease. And the coagulation profile was within normal limits, and the cultures were done outside were normal, and the peripheral smear showed anisopoikilocytosis. And in view of the relative bradycardia, an echo was done there, which showed a sinus bradycardia with a normal ejection fraction. And the hepatitis panel done was negative, and also the serologies for dengue, scrub, Vidal, and malaria were also negative, and the lepto-IgM was found to be positive. And on receiving him on the day 10 of his illness, we had repeated the blood investigations. Here we had a mild leukocytosis with a total count of 12,500. The platelet was near normal, that is 1.45 lakh. ESR was decreasing, and CRP, according to our cutoff, was actually normal. CRP was less than 10. And in the bilirubin part, the total bilirubin was elevated, and again the majority was contributed by the direct bilirubin. Protein, albumin, globulin were normal. Transaminases, again SGPT was more than SGOT. And in the RFT part, the urea was normalizing and the creatinine was within normal limits with a normal sodium and potassium. And we had also repeated the ECG, which showed a sinus bradycardia with no heart blocks. And we also did an ultrasound abdomen, which was found to be within normal limits with no hepatosplenomegaly or ascites noted. And the peripheral smear showed no evidence of hemolysis. We had also sent for the autoimmune panel, that is ANA, anti-SMA and anti-LKM, which came as negative. The serum ceruloplasmin level and the serum copper levels were also within the normal limits.
Any comments about doing a serum copper? In how far it's useful in the diagnosis of Wilson's?
Not much reliable, madam. Serum ceruloplasmin and 24-hour urinary copper would have been a better option.
Yeah, then why didn't you do that? It was done, or because ceruloplasmin was normal, you just
I just
other than doing a serum copper, it would have been better to do a
urinary copper.
What happens?
Copper X. There would be since a low serum ceruloplasmin level is low, the copper binding will be reduced and the more of copper will get excreted through the urine.
Yeah, more of urinary copper. Might I still be go with the challenge with the depensilamine or just a random? Is there any change in the school of thought?
It is a change, man. Actually, theoretically or as per the guidelines, now we have this Indian societies have come up with the guidelines for Wilson's disease diagnosis. So there they don't recommend the challenge, penicillamine challenge test, only the serum copper and 24-hour urine copper. Anything more than 40 is likely, but more than 100 is highly suggestive, or it is diagnostic.
Okay.
But
as far as the general pediatrician, they are still no, okay, you have to the challenge with the penicillamine, say 500 milligram, and then collect the urine and then give one more dose. And then
they don't recommend it now.
Yeah, now they're not recommending. It just 24-hour urine copper, and if it is more than 40, that is something abnormal. But as you said, if it is more than 100, definitely you can take it as positive. Serum copper, I think it can be in low or normal or even high. So that's not very reliable investigation. So ceruloplasmin and the 24-hour urine copper. Okay, that's very important. But from these investigations, from all these investigations available, I think it's so typical of a leptospirosis, right? Okay, go ahead, next.
And in our hospital, he was treated with parenteral doxycycline along with other supportive medications. And we were monitoring his LFT and electrolytes serially with strict vital starting. We had done an ophthalmology consultation and KF rings were ruled out. And he improved symptomatically and he was febrile from the 4th day post-admission. And at discharge, his parameters were within normal limits with a decreasing value of bilirubin and a normalizing value of SGOT.
Did he receive any antibiotic from the local hospital?
He had been given crystalline penicillin, madam.
Okay. So why did you change the antibiotics? Which are the antibiotics of choice for leptospira?
In unstable patients, we can either go for crystalline penicillin or parenteral doxy. And for stable patients, we can go for ceftriaxone, cefotaxime, as macrolide antibiotics, oral doxycycline.
Okay, oral doxycycline or even ampicillin, amoxicillin, all I think azithromycin, everything will do. But normally for a sick patient only, we start with a ceftriaxone. So why do you want to go for a parenteral doxycycline? That's said to be more effective. I don't know. How many days?
He was given a parenteral doxy here for 5 days, madam.
The dosage?
2 mg.
Okay, it's almost like an adult, 16 years, and he looks like an adult. So you can give the adult dosage, 100. Okay. So lepto, I think, is there any particular reason why did you go for a parenteral, Gopika?
No, madam. Actually, since he was not responding with the CP, we thought of second line like IV doxy. We didn't think oral doxycycline.
Well, normally then we go for a subtraction and all, no?
But,
Subtraction. But it was okay, right? I was just asking why. Okay, right.
and
Now-
actually they started doxy there, and then even after 2 days of doxy, he was not improving. They referred like that. So it would have been better.
So somebody had put a
with that
question,
doxy.
somebody had put a question like lepto IgM level. Was it a quantitative or a qualitative test only? Any titer available?
No, only one test
This
was
is,
given.
it's
Titer
still,
on that. Silpa?
as he responded, it's fine. Otherwise, high false positivity is there for lepto. I think that's why they're asking the titers.
32.575. But here I think clinically, I think we should not rely exclusively on the lab. I think more like a clinical. So the clinically everything is compatible.
He's
So we
responded.
can- yeah, responded with that. Okay, how do you manage? Suppose it turns out to be a means the Wilson's. How do you manage?
We can give copper chelators like D-penicillamine, madam.
How much? Because one of your differential diagnosis is Wilson's.
1 gram.
Adult boya. Where is milligram per kilogram?
20 mg per kg.
Okay, roughly. How long and how do you monitor? Along with that, what else?
Zinc can be given as a
Okay.
copper.
Why? What is the rationale of zinc in the treatment?
By transport of metal transport.
So,
Competitively,
it decreases the absorption of copper, right? Decreases the absorption of the copper from the intestine. And then you monitor, and the 24-hour urine copper is reduces the copper absorption that you said. The 24-hour urine copper excretion has come back to nil. Then how do you manage? How long and how do you? Okay, Maya, I want to take over the management of Wilson's.
Wilson's, the drug of choice is always been D-penicillamine. In patients who have hepatic presentation alone, we can start very well with the full dose and monitor the counts and looking for drop in, because this can affect the bone marrow. So that is how we manage. But neuro Wilson's, we have to be very, very careful, because when you start on penicillamine, they may worsen. So there are times when we start with 1/4 the dose and then slowly start hiking up. Maybe weekly, there are certain protocols or certain guidelines. They say 1 weekly or 2 weekly, but some people prefer to do it monthly, because the worsening of our neuro Wilson's is really bothersome. There's an alternative which was never earlier not available in India. Now we have tried it, but it's very, very expensive, because these drugs need to be going on for a long time. And in asymptomatic Wilson's, we usually prefer to give only zinc. And also not to forget all the dietary restrictions which are to be taken care of when we prescribe these, once you diagnose Wilson's, because many of the the food which we consume on a daily basis have high copper, so that also need to be taken into account.
Is there any need to add pyridoxine when you give a D-penicillamine?
Yes,
That's another
we always
important
add.
point.
It is mandatory to add, because this will bind to the other metals, so there will be a relative deficiency of pyridoxine, so we have to add.
Add with, and then one
Always
more,
been
I
adding,
think,
yes, madam. You also been writing pyridoxine. Ellen?
yeah, right. And once that urine copper has become normal, do you want to stop D-penicillamine and then continue them on a single maintenance with zinc alone? That has also been suggested by, I think, Dr. John Mathai and all used to tell us.
Generally, we have patients like where I'm working, we have the hepatology unit has been there for a long time. So I've seen patients who are like diagnosed in childhood, 20 years, 30 years. But what we see is they are maintained on the same penicillamine and monitor to see the urine copper on a yearly basis, and to look whether they fall into the prescribed. It should not be too high, nor should it be too low. If it's too low, that means you're overchelating the child. If it's too high, means that your chelation dose is not effective. So accordingly, we adjust the dose of penicillamine. But recently, I saw a child who was diagnosed with Wilson's. They stopped and they have penicillamine, and they come back with neurological manifestation. It was only hepatic, but in the last 10 years, because I think he improved, they stopped, and now he's developed cirrhosis as well as neurological Wilson. So I don't think, to my knowledge, that is, I don't know.
I think there is one school of thought like that, because once we have the chelation has been completed, and then you can manage with
Manage on zinc
further
alone.
absorption. Yeah, I think again there's two different schools of thought to this one. And then one important thing, as Maya said regarding this, that always it is mandatory to screen the siblings, because we know it's a autosomal recessive, and if there is anything that is you screen with the hair-free as well as the 24-hour urine copper, if that is high but child is asymptomatic, they definitely put the child on zinc. So that is another this thing. Okay, that's about Wilson's. And then if it's an autoimmune hepatitis, how do you manage? Immediately, we'll just quickly finish off this.
High dose steroids can be given, madam, prednisone,
Ah.
or other immunosuppressants like azathioprine or 6-mercaptopurine, or
Depending on, right? You start with the steroids,
and
gradually taper off, but definitely how we are going to monitor that by the parameters, or you have to do a biopsy. Repeat biopsy or parameters is enough. Maya? Take over.
Conventionally, as Madam said, we start on 2 mg per kg of steroids, and if need arises, we would add on azathioprine. Now, recently, we also has budesonide, which can be used in mild autoimmune diseases, which they have because they have a very high first pass metabolism in the liver. So we can get away with the systemic side effects of steroids. So there are many preparations which are available, but these are recommended only in milder diseases. Those who present with jaundice like this, if this patient was ever diagnosed, we would prefer to go for steroids plus minus azathioprine. There are other immunosuppressants like mycophenolate mofetate and things like that. The monitoring, we would be more or less a clinical monitoring with liver enzymes, AST, ALT, the immunoglobulin levels, and the autoimmune markers, which we monitor periodically. And as there is a school of thought that this may be spontaneous, they may undergo spontaneous resolution, and we may be able to take off the steroids. At that point of time, definitely a biopsy is mandatory. So usually at 3 years or 4 years, we can attempt, if the child has been in remission for a long period of time, we can attempt, but that time, because AST and ALT may not be truly representative. So we have to do a biopsy. We have to document that the disease is not active even in the microscopic level, and then we can try weaning, but under close monitoring. If he comes back with again features of, or again LFT alteration, we have to restart, and then there is no looking back. Then we never try to wean off the steroids.
Okay, I think we have almost covered. Anything else anyone wants to ask or something? Otherwise, we can wind up. Any of the postgraduate students who are, or even the faculty? I think it was really an excellent presentation, Silpa. Congrats to you. I think you have covered it good, I think, in a very good presentation, and congrats to you as well as to the mentor Gopika. You have trained her very well.
Thank you, ma'am. It was an exhaustive discussion, and actually it was, we are very glad that IAP Trivandrum and Kerala has given Anandaburi Hospital this opportunity. And going back to our PG days, it was long back, but still fresh, and it was a very exhaustive and very, it was like a flow.
I also learned a lot of new things from Maya. Right.
Madam, you're all like
You're
my
actually
family.
missing, madam, your classes and
It's like deja vu for me.
Yeah,
Like,
deja
I've
vu.
been listening to you since MBBS. And I joined
have more
you,
of this.
worked with you for 4 years now. And I like, I've away been from Trivandrum SCT. Now it's like coming home, coming back.
Yes,
and
yes.
meeting all of you.
Yes. Mm.
Okay, any of the participants?
Congratulations, Silpa, Dr. Gopika.
Purshu, you want to add something?
Nothing.
Purshu, ആദ്യമേ ഞാൻ പറഞ്ഞ മിണ്ടല്ലേ എന്ന്.
Oh, ഇല്ല madam, നന്നായിരുന്നു. We are
In
enjoying the
between.
discussion. നന്നായിരുന്നു madam, നന്നായിരുന്നു.
നല്ല
As
presentation
madam said,
ആയിരുന്നു.
Silpa, the last part of your diagnosis in the provision diagnosis in the madam പറഞ്ഞ മാതിരി
കുറേ എഴുതണ്ടല്ലോ.
division അല്ല, number 1, number 2, number 3, number 4. No, that's very important. One thing is about when you're considering the inspection part, the gallbladder and all is more visible than palpable. When you're considering the possibility of cholangitis and colicky pain situations, always include inspection before palpation.
Okay.
Gallbladder is more visible than palpable.
Okay, anyone from the IAP? Otherwise, we will wind up. അല്ലേ?
Thank you, madam. Thank you, Maya.
Thank you, everyone. Okay.
Thank
Okay,
you, all
madam.
the senior faculties. Sushma madam was there. Purushottam sir was there. Thank you. So it was a great, we'll call it a day. Thank you, ma'am.
Okay, then thank you, Willy.
Thank you.
Thank
madam.
you.
madam.
Thank you.
Good night.
Good night.
Hello.
Hello.
Ma'am.
Hello.
കൽപ്പന,
Kalpana madam.
ഒരു official vote of thanks പറഞ്ഞപ്പോ ഞങ്ങളെല്ലാം പോകാം.
Madam, it was a very great session, madam. It was, I enjoyed. I just went for a minute only. I was here only. And Purushottam sir is there. Sir always. Okay. Maya, thank you very much for being with us because we
Pleasure,
have
madam.
seen you for quite a long time back only. We are having contact, but still we are not seeing, isn't it? And it was a very nice session. Madam, it is appearing just like your case discussion in city.
Okay. I'm still continuing that, no? That is why. Thank you.
We'll meet again.
Thank you, madam. Thank you, Maya.
Thank you, Maya.
Kalpana madam, thank you for giving us the opportunity.
Thank you for inviting me.
It was very nice that you have agreed our first instance so that I didn't want to look for other people. Just I asked and she immediately agreed.
It's always pleasure to come back home.
Okay.
Thank you.
Okay, Maya, leave.
Bye.
Good night.
Bye. Good night.